Thanks so much, Mark. It's great to be here again at the PCRI, and excited to talk about what I think are the hottest topics in prostate cancer right now. There's a lot of things happening in this field. I mean, we're fortunate to be in a field where there's a lot of great advancements occurring over and over again. So I'll go ahead and start by sharing my disclosures. I'll just leave this up for a second. And then I'm going to move ahead now and talk about first the metastatic hormone-sensitive prostate cancer state. I think there's been a lot of new findings and things that are happening in this disease state with metastatic hormone-sensitive prostate cancer. And I want to talk about some of the newest study results that are going to change standard of care or have already changed standard of care. And also I'm going to focus on who we should be doing this for. So let me quickly summarize again. When I say metastatic, that means that it's prostate cancer that's left the prostate and has spread to a distant site. As we know, prostate cancer likes to go to lymph nodes, it likes to go to bone, but it can go to sites like the liver or lung, places like that. When I say hormone-sensitive prostate cancer, there's a lot of terms that can be used. People use the term hormone-sensitive, people use the term castration-sensitive or hormone-naive. These are essentially patients who haven't received hormone therapy or testosterone-lowering therapy yet, androgen deprivation therapy. And so that's what I mean. So you get a scan, CAT scan, bone scan, you see maybe some cancer that's spread to the bones. They haven't received any medications to lower testosterone, for instance, like Lupron or Degarelix, anything like that. So that's the disease state I want to talk about first. And what this slide summarizes are just a whole bunch of the different treatment options available, because as of now, or as of a year ago, we had a lot of options already. So the first thing that came about was docetaxel, chemotherapy. We know that if we add 6 cycles of docetaxel chemotherapy to hormonal therapy for patients with this disease state, that there can be survival benefit. That's from the CHARTED trial and the STAMPEDE trial. Now, in that study, in the CHARTED study, they broke it down further and they found that the patients who garnered the most benefit from chemotherapy were those who had kind of high volumes of disease, meaning it spread to the liver, the lungs, or they had at least 4 or more bone metastases with one outside of the middle of the spine or the pelvic region. So let's say the humerus, like arm, the leg region, those would be considered appendicular or part of an appendix, and that would put you into a high volume disease category if you had 4 or more of those lesions. Interestingly, docetaxel's been around for a long time, so it didn't really require an FDA approval. So as you can see on this slide, it's not in one of those boxes. The drugs that are in the boxes are drugs like abiraterone that showed significant survival benefit for metastatic hormone-sensitive prostate cancer patients up front in the STAMPEDE trial, in the Latitude, and now in PEACE-1. So abiraterone is a drug that lowers testosterone production everywhere in the body, not just in the testicles, but in the tumor itself, in the adrenal gland, all the places where testosterone can be made. And the other boxes show apalutamide from the TITAN study and enzalutamide from the ARCHES and ENZAMET study. Now, these are pure androgen receptor antagonists. What that means is they bind to the hormone receptor that testosterone binds to, and they don't let go. They're irreversible, so they completely inhibit the effects. So to summarize this slide, let's start with the base that we know that treatment intensification of patients with metastatic hormone-sensitive prostate cancer leads to dramatic survival benefit, and that can be treatment intensification with chemotherapy, docetaxel for high volumes of disease, or with really potent hormonal therapies like abiraterone, apalutamide, or enzalutamide. Okay, let's move in to more recent studies. PEACE-1 was first presented at ESMO, European Society of Medical Oncology, last year. Okay, and this was an interesting study. This was interesting in the fact that they only allowed patients with de novo metastatic hormone-sensitive prostate cancer on. When I say de novo, I mean that when they were diagnosed, they already had metastatic disease. Now, most people in the United States present with not de novo, or what some would call synchronous metastatic prostate cancer. They present with metachronous disease, which means maybe you had prostate cancer in your prostate, you had surgery or radiation, and years later it came back and became metastatic. That's not who this study looked at. This study looked at patients who had more aggressive features who presented with de novo metastatic hormone-sensitive prostate cancer. And there were 4 arms to this study, but really what they were asking are 2 questions. Question 1, does abiraterone lead to significant benefit? Now, we already know that from the STAMPEDE study and the LAD2 study, and so I'll just quickly answer that yes, in this study it did as well. But the second question they asked is, does radiation to the prostate, in somebody who already has metastatic disease that we consider essentially incurable, but does radiation to the prostate maybe reduce the tumor burden and lead to better outcomes, survival outcomes down the road? That has yet to read out. We haven't seen data from that yet, so I'm not going to talk about that today. What I find to be most interesting from this study, however, is what I'm presenting on this next slide, which is that in this study initially, they didn't necessarily have patients who received docetaxel chemotherapy, but the CHARTED trial led to a lot of excitement. And so a good chunk of the patients, some of the patients on the study, received both hormonal therapy and docetaxel. So we're able to learn from this study a unique feature about triple combination therapy. Well, we know docetaxel adds benefit for high volume disease. We know that abiraterone adds benefit for all comers. But does abiraterone add benefit on top of getting the hormonal therapy, androgen deprivation therapy, and docetaxel? And that's the unique finding from this study that shows that the median survival benefit for these kind of de novo patients who had high volumes of disease, it wasn't low volume disease patients, it was high volumes of disease, so aggressive characteristic patients, prostate cancer patients, added a median of 1.5 year or more survival benefit. I think it was like 1.6 years in this patient population. So this was the first evidence that showed triple combination therapy with both your hormonal shots, with adding the abiraterone pills, and with adding chemotherapy, docetaxel chemotherapy, that this triple combination has benefit. Okay? That's pretty cool. Now, another study called the Arison study. This was really just presented at GU ASCO in February of this year and is published in the New England Journal already. This was a very clean study. This study was slightly different. It was also patients with metastatic hormone-sensitive prostate cancer, but it took patients who were on androgen deprivation therapy, and everybody received docetaxel. Okay, so the entire population. So everybody got androgen deprivation therapy and docetaxel, and half the patients got darolutamide, which is another pure androgen receptor antagonist like enzalutamide or like apalutamide, and half the patients just got placebo. So it was essentially androgen deprivation therapy with docetaxel, with or without darolutamide. Overall survival being the primary endpoint, and I want to focus first on the key baseline characteristics. So this study had different eligibility criteria from piece 1, where it was androgen deprivation therapy, docetaxel, abiraterone. That required de novo metastatic disease, and what we've seen is the data for the high volume disease patients. We haven't seen much of the low volume disease patient population data yet. But in this Arison study, what we find is that eligibility requires just being fit enough for docetaxel. So it was really dealer's choice, up to the investigator, up to the patient. If you were fit for docetaxel, could tolerate chemotherapy. Now, logically speaking, not everybody's going to want to go on this study. So in a lot of centers where patients had other options, they might have gotten androgen deprivation therapy or an abiraterone or androgen deprivation therapy and apalutamide. And then they've hand-selected the most aggressive patients to go on this study. And that's why I want to focus on this baseline characteristics slide. You can see with the red, circle there, I'm emphasizing the fact that 86% of the patients presented with distant metastases. So this whole synchronous metastatic, de novo metastatic population. So in some ways, it's very similar to the piece 1 study population in the fact that most of these patients had aggressive characteristics. They didn't have surgery or radiation or relapse 10 years later. They presented with metastatic disease. So that's why I want to focus on this slide. Now, the next slide is just the overall survival data. This is the top line data. You can see there's a 32.5% reduction in the risk of death. with a very significant p-value, which is a statistical marker that we look at. But even to the bare eye, one can see the survival curves separate rather early and are quite distinct. So again, this is more evidence to support the idea of triple combination therapy, where you're getting the hormone shots, you're taking a hormonal pill, whether it's abiraterone from piece 1 or darolutamide from the Arison study, and you're getting 6 cycles of docetaxel chemotherapy. For this patient population, which has more aggressive characteristics, very, very, very clear survival benefit. Now, I will tell you that about 86% did have de novo metastases. Less than that, a smaller subset, what was remaining, had recurrent metastatic disease. That wasn't statistically significant, but close. Okay, so again, I think there's hints that triple combination therapy might help everybody, but most convincing for those who present with metastatic disease. Now, this is a busy slide that looks at the adverse events or the side effects on the study. And I'll just point out, when you look at the left column, it's triple combination therapy, androgen deprivation therapy, darolutamide, docetaxel. When you look at the right, it's more just androgen deprivation therapy, docetaxel on placebo. So you can see that most of the side effects are probably chemotherapy side effects, the docetaxel side effects. But the areas where there's difference, I'll point out, are rash and hypertension. It's slightly more, not even a lot more, but there's a little bit more rash, and then there's a little bit more high blood pressure in the patients who got darolutamide. But it seems like most of the side effect profile is driven by the chemotherapy. So this is really, really well tolerated. All right, I want to close this section on metastatic hormone-sensitive prostate cancer, and I just want to go over the take-home messages. I bolded the most important ones that I think are standard of care, or that change standard of care. So for patients that are fit for docetaxel, that means healthy enough to receive it, and who have de novo metastatic prostate cancer, and again, de novo means presenting with metastatic disease, not having treatment of the prostate and recurring later with it. For this patient population, triple combination therapy leads to significant overall survival benefit. And what triple combination therapy is, your testosterone lowering shots, androgen deprivation therapy, okay? Chemotherapy with docetaxel for 6 cycles, and then either abiraterone from piece 1 or darolutamide from the Arison trial. This leads to an overall survival benefit, but I will emphasize, this is not for everybody. This is for patients who have more aggressive characteristics. I assume most of these patients had high volume disease, and that clearly most of the patients had de novo metastatic disease where they presented with these metastases. So it's not for everybody. It's for patients with these most aggressive characteristics. But one could argue these are the patients that do the worst. It's the biggest unmet need, so I'm glad that we have this here now. Now, eventually we need to do post hoc or after the fact analyses to look at the breakdown for the low volume disease patients. We'll have to dissect that data to show, when we get more data for those with just very, very few metastases, is there a benefit to triple combination therapy. And I want to emphasize that if you have metastatic prostate cancer, even if you don't have these kind of really aggressive, poor prognostic characteristics, treatment intensification is still warranted in the vast majority of patients. And there is some post-marketing data out there that shows that a lot of people, maybe half of people with metastatic prostate cancer, aren't getting any treatment intensification. So triple therapy is not for everybody, but some sort of treatment intensification, adding abiraterone or enzalutamide or apalutamide, or docetaxel for those really higher volume subsets. Some sort of treatment intensification or doublet therapy is warranted for the vast majority of patients as long as you're healthy enough to tolerate it, okay? So I'll wrap that section up, and I'm going to move to the next section, what I consider hot topic, by asking about PARP inhibitors. Okay, now we know about PARP inhibitors a little bit. Okay, these seems like it's beneficial for patients who have certain gene mutations in genes that lead to problems with DNA repair. You get breaks in your DNA, doesn't repair very well. Okay, that's often what leads to cancer, but it also leads to a susceptibility to treating cancer cells that can't repair their DNA very well. So there are these PARP inhibitors out there that are FDA approved. And the question here really is, there's new data that might hint towards expanding the patient population that we should be treating with PARP inhibitors. So I'm going to talk about that. So first slide, I want to summarize the FDA approval for PARP inhibitors. There's really 2 PARP inhibitors that are FDA approved in prostate cancer. One is from the PROfound study using a PARP inhibitor called olaparib. Okay, and these studied patients who had metastatic, castration-resistant, or hormone-resistant prostate cancer that have progressed on either prior enzalutamide or abiraterone. So the difference between this disease state and the previous disease state, you have metastatic disease, you can see it on your scans, but the difference is you've already received the potent hormonal therapies and your PSA is rising or your scans have gotten worse, you have progressed beyond that. That is now metastatic, castration-resistant prostate cancer. The other key thing to make patients eligible for this study with olaparib is you had to have one of, I think, 16 different DNA gene repair mutations. So they had a panel of genes involved in DNA repair, and they stated that if you have one of these mutations, you might have a higher likelihood of responding to a PARP inhibitor. And the way that this works is let's think about this, is double-strand DNA break repair, or something we call homologous recombination repair, is one of the best ways for cells to repair their DNA when there's errors that occur. There's lots of different DNA repair mechanisms. But these patients with one of these mutations have lost the ability to do that well. Now, how does PARP work? PARP works by basically helping with single-strand break repair. So you've taken out double-strand break repair by having one of these mutations. And now you have a PARP inhibitor, so you take out single-strand break repair, and these cancer cells that just can't repair their DNA, they try to divide, repair things, and they get stuck, and then they die. So that's the way that a drug like olaparib works if you have one of these 16, it's actually, the label actually I think had 15 genes, because one of the genes it didn't seem to work very well for. Now, the bottom of this slide emphasizes the other PARP inhibitor that's FDA approved, that's rucaparib. And I don't think one of these PARP inhibitors is clearly better than another, but they studied it in a different patient population. They looked at patients who had already had drugs like abiraterone and enzalutamide and also had a taxane chemotherapy. So it's FDA approved for a later setting, and their data was best for patients with one of 2 DNA repair gene mutations, and it was BRCA1 or BRCA2. So they have a more narrow label, and that label is for post-chemotherapy patients and patients who have to have a BRCA1 or 2 gene repair mutation. Now, frankly, I like this label because I think most of the patients with DNA repair gene alteration problems, it's driven by BRCA2 in prostate cancer. There's much less being driven by the other genes. I'm just going to throw out a bunch of names, ATM, PALB2, RAD51. There's a whole bunch of other genes. It's less clear how important those genes are. BRCA2, no-brainer, okay? These drugs work for patients with those mutations. So again, this is where we're starting from. You have one of those DNA repair gene mutations. With olaparib, you don't have to have received chemo. With rucaparib, you have to have received prior dose of Taxol. So you have to have one of these biomarkers selected through next generation sequencing. And so these mutations are usually found either in the tumor or can be found by plucking your tumor DNA out of the blood. Okay, you have to have one of these mutations, one would think, to respond well to PARP inhibitors. Well, let's ask this question again. At GU ASCO this year, the randomized phase 3 magnitude study was presented. And this used a PARP inhibitor called niraparib, a different PARP inhibitor. And this required biomarker selection with a more limited panel. It was a panel of around, I think, 8 genes, maybe it was an 8 gene panel, okay? And if you were biomarker positive for one of these DNA repair genes, they put you into randomization of adding niraparib to abiraterone or abiraterone alone. First line therapy for metastatic castration-resistant prostate cancer, okay? If you're a biomarker negative, meaning you didn't have a DNA repair gene mutation, they had the same randomization. They just put you in a different group of 600 patients planned. And the primary endpoint was not overall survival, it was radiographic progression-free survival. So really essentially time until your scans look worse. All right? Now first they had a futility analysis of the biomarker negative group. And the biomarker negative group, one, has less scientific rationale to think it'll work. So they did this composite progression endpoint looking at either radiographic imaging progression or PSA progression, PSA going up. And they found that niraparib didn't seem to help. So they just said, we're shutting this arm down. Okay? Now this next slide, however, looks at the primary endpoint of those who are mutated in either BRCA1 or BRCA2. And they had a very significant improvement in radiographic progression-free survival by both central review, where the images were sent in, or some central blinded radiologists, and by independent investigator review. So that's pretty interesting and promising that the combination of adding the niraparib early, because right now the data is with PARP inhibitors later, and it's with PARP inhibitors single agent. But this is combination with abiraterone, and there is a radiographic progression-free survival benefit with adding niraparib here. Now this next slide here doesn't just look at those with BRCA1 and 2, it expands to the whole 8-gene profile and includes all those other patients. You can see the curves are a little bit more narrow. Okay, there's not as much difference between the curves. Probably because most of the benefit's still driven by BRCA2 and BRCA1. But there are some patients with these select other gene mutations that might benefit as well. Tough to tease that out. But still positive for this endpoint using all this biomarker panel positivity. Okay? Now, overall survival, I think it's almost useless showing this because patients are going to live a lot longer beyond their radiographic progression. You can see the survival curves, there's no clear difference, but that's because this data isn't mature. When I say it's not mature, it means they haven't followed the patients out long enough. You need to follow the patients out longer to potentially see an overall survival benefit. But I would propose that this is very interesting, not for the biomarker negative patients, but for the patients with DNA repair gene alterations. One asks the question, maybe we should be using these PARP inhibitors early in combination with abiraterone right up front, okay? But the study doesn't answer a key question. And the key question is, when you combine the two drugs together, is that better than giving them in sequence? So you give somebody abiraterone and follow it up with a PARP inhibitor, or you give somebody a PARP inhibitor and you follow it up with abiraterone, maybe they do just as well. And so just because we can combine doesn't mean we should, because combination might lead to more side effects, more costs to you as a patient, more costs to the healthcare system. Can't tell yet from this study. It's a little bit early. So this next slide is from ASCO. And this was presented by Maha Hussein. It's a little bit of a teaser. It's called the Breakaway study. And this was a small study with 3 different arms. And it kind of tried to ask this question, which is the question of, does combination of abiraterone with a PARP inhibitor, and then the PARP inhibitor they used here was olaparib, do you do better than giving olaparib followed by abiraterone, or abiraterone followed by olaparib? And again, 20 patients per arm, not enough statistical power to show too much, certainly not for overall survival, but they did show that radiographic progression-free survival seemed better to the combination right up front than one followed by the next. Still doesn't answer the question. What I want to see is overall survival is improved to combination up front versus given one after the next, because I don't think any of the studies answer that question. But still very provocative and interesting data. Now this next study I'm going to talk about is the PROpel study. This was also presented at GU ASCO, and this was a really interesting design in the fact that, like Magnitude, they accepted patients that had biomarker positivity or biomarker negativity, but they didn't even test up front. They just took everybody. You're eligible with metastatic castration-resistant prostate cancer for abiraterone. Well, we're going to randomize you to abiraterone plus placebo or abiraterone plus olaparib. And it doesn't matter whether you have a DNA gene repair mutation. We're going to test for it, and then we're going to break down the data later based on whether you have it or not. But we're really looking at all comers because there was a randomized phase 2 study earlier that kind of showed benefit. radiographic progression-free survival benefit. And the field's had a hard time wrapping their arms around it because we just don't understand, if you don't have one of these DNA gene repair mutations, how does the PARP inhibitor work? We don't really know. There's a little bit of preclinical data that shows that, hey, when you suppress the hormonal pathways, you might be upregulating the DNA repair pathways. And so, hitting that pathway is important as well. And vice versa. That when you hit the DNA repair gene pathways, that it might have caused changes in the hormonal androgen receptor or testosterone pathways. So maybe hitting them both together might be synergistic or at least additive. Regardless, they took all comers and they looked at radiographic progression-free survival. And you can see by this next slide here that you have a radiographic progression-free survival benefit there. Median RPFS, or radiographic progression-free survival, went from 16.6 to 24.8 months. Very statistically significant p-value, which again is that marker we look at for statistical significance. And I'd say this is pretty impressive for a patient population that was unselected. There was no biomarker selection here, so it's really quite interesting. It's not like the first time this was done. This was a confirmatory randomized phase 3 study for a randomized phase 2 that showed very similar data. Now this next slide looks at subgroups. So we always have to take this with a grain of salt, because once you start looking at specific subgroups, you decrease your statistical power because it's smaller patient populations. But one of the important things here that I highlighted in the red circle is the HRR, or homologous recombination repair mutation status. And I want to point out that when you look at these plots, what you're looking at is a hazard ratio of 1, and 1 means there's no benefit at all. What you want to be is you want to be on the left. You want to show that adding your new drug, olaparib, let's say, on top of abiraterone, leads to reduction in the risk of death. Okay, so if 1 is the number, you want to be less than 1. Okay, and you can see here that for the homologous recombination mutated patient population, it's very far to the left, way less than 1. And that makes sense because we already know that olaparib adds benefit for these patients. It's already FDA approved, as I said in the beginning. But again, when you just look at the subgroup of those that are not mutated, it's still not only to the left of 1, smaller than 1, but the entire statistical confidence interval, 95% confidence interval, which, statistical speak allows some margin of error, a 95% margin of error. The entire interval falls to the left of 1. Pretty interesting here. So I think, this is provocative data. Now, overall survival on this next slide, similar to the magnitude study, data's not mature. Okay, the good news is not enough patients have passed away for the data to be mature. That's good news for those patients. But, it doesn't give us a final answer yet for overall survival. So this is my take-home message slide. And on this slide, I want to, again, highlight it that olaparib's already FDA approved. But it's FDA approved for those with select DNA repair gene alterations. I think it's a 15-gene panel that's approved for. In the post-novel hormonal therapy setting, that means post-abiraterone and enzalutamide, generally speaking. Metastatic castration-resistant prostate cancer. Rucaparib, also FDA approved, but the difference is you have to have received prior taxane chemotherapy as well as the prior novel hormonal therapy, and the gene mutations are limited to BRCA1 or 2. But the new stuff that I'm still trying to digest, I'm sure the FDA will take some time to digest, but doesn't change things just yet, but might be a nice glimpse at the future to come. Adding niraparib to abiraterone for first-line metastatic castration-resistant prostate cancer for patients with one of 8 DNA repair gene mutations seems to have some short-term benefits for radiographic progression-free survival. We got to follow these patients out to see about overall survival. And the real question is, do you need to do it together up front, or can you do it in sequence? The other take-home is for a biomarker unselected population, which is even more interesting in the fact that I can't say I understand how this works yet, but adding olaparib to patients for first-line abiraterone who have metastatic castration-resistant prostate cancer. That also leads to short-term benefits for radiographic progression-free survival. We'll have to see for long-term benefits. The real question is, I don't know how this works for those who are DNA repair gene non-mutated. What's the biologic mechanism for driving that? Will this be enough to drive FDA or regulatory approval and use down the road? And the reason it's important is that one might say, well, even if there's not overall survival, even if we don't understand how it works, maybe it's fine. Just throw it in the water. Yeah, that's fine, but we always have to remember the downsides to our treatments. Treatments, there's no free lunch in life. Treatments have side effects. Treatments have costs. And so we really have to be convinced that the data is, overwhelmingly, convincingly there, and that we're helping our patients this way. And so I think the jury's still not quite out, but it's an interesting glimpse. All right? Now, the next section, I want to talk about Lutetium PSMA 617. You've all heard of this. It's been given in Germany and Australia. We now have data to support it. What I want to talk about is how do we sequence it with chemotherapy, with cabazitaxel. There's some new data on that. And I also want to talk about who does the best with this. How do we pick patients for this? How might we help select patients? So this first slide here is just the VISION trial. This was presented way back in ASCO 2021. I mean, that's like over a year ago now. That's like ancient history now. This field moves so fast. But that being said and done, I got to show you this slide to show you that there's clear overall survival benefit. And what the label is for patients who have metastatic castration-resistant prostate cancer, have received a prior novel hormonal therapy, and have received a prior taxane chemotherapy. You don't have to receive 2 or 3 of each. You could have, but you have to have at least received 1, and you also have to undergo a PSMA PET. Now, PSMA is prostate-specific membrane antigen. It's not PSA, it's PSMA. This is a protein that's highly expressed in prostate cancer cells. Probably 85, 90+% of patients with metastatic prostate cancer will express this at a high level. And all this drug is basically a small molecule that finds PSMA and it drops off radiation, potent radiation, right inside those cancer cells after the cancer cells uptake it. So it's pretty cool. It's like a liquid radiation delivery mechanism. We call it Theranostics. We call it radioligand therapy. You can call it what it wants to. I say it works well. I mean, that's what the data shows, right? So on this next slide, however, this just goes to show that how we can maybe pick better who the patients are going to do the best with this therapy. And what it shows is that if you look at mean SUV, and SUV is just a way of quantifying your measurement of uptake on a PET scan, that those patients, it's kind of common sense, those patients that uptake the most PET radiotracer for PSMA, they're going to be the patients who do the best with Lutetium 617 PSMA. Makes sense, right? That's not to say if you don't uptake much that you're going to do poorly. You're going to still gain benefit over what their control arm which was switched to another novel hormonal therapy. It's just not as much benefit. And this can become relevant later, and I'll talk about that. Now, on the right panel there, you can see that the patients who did a little bit worse had PSMA positive lesions in, let's say, the liver or in bone. So if your PSMA PET lesions are isolated just to the lymph nodes, you're apt to do the best here with Lutetium 617 PSMA. So that helps us pick out patients a little bit better. Now, this addresses the issue of comparison with chemotherapy. This was a nicely done study from Australia and New Zealand called the Therapy Study. And in it, they took patients, and they had very stringent criteria. They had to have a lot of PSMA PET uptake and no FDG uptake because they were worried that that might be some sort of weird variant of prostate cancer that doesn't make a lot of PSMA, that's, just has a very, very high glucose uptake rate. That's FDG. And they compared those patients with Lutetium PSMA 617 to patients receiving cabazitaxel chemotherapy. So it was clearly a post-docetaxel chemotherapy population. Primary endpoint was PSA response in favor of lutetium over cabazitaxel, which we know to be good. Cabazitaxel is already proven to be better than switching from one hormone therapy to the next in the CARD trials published in the New England Journal. But this has hints that maybe PSA response, better with lutetium. Progression-free survival, combining composite criteria of PSA and imaging radiographic, better for lutetium. Side effects, better. I mean, you get some unique things with lutetium. You get some dry mouth, dry tears, drying out your eyes. But you get much less suppression of your blood counts, much less suppression of your immune system, neutropenia, neutrophils, which are your infection-fighting cells, much less suppression of your platelet counts. So in general, less toxic. Pretty interesting data, but the thing is, it wasn't a registration study, not significant data for overall survival, as I'm showing in this slide. This was an update that we just had at ASCO 2022. No difference in overall survival, but I will point out, the study was not statistically powered to show overall survival. You would need a bigger study, more patients, to really be able to show that benefit. Okay, but what we did learn recently this year is from GU ASCO, similar to the VISION trial where we had that data from ASCO showing higher PET uptake, mean SUV being higher, patients more apt to do better with lutetium 617. Similarly here in this study, therapy, if your SUV PET mean uptake was greater than or equal to 10, again, their quantifiable measure, those patients had much better outcomes with lutetium PSMA versus chemo, versus the ones that had lower uptake, still better than chemotherapy, but not so much better. So again, I think we can use some of this data. My take home that I put in bold here on this next slide is that although there's no overall survival benefit in the therapy trial for lutetium 617 PSMA over cabazitaxel for patients who have metastatic castration-resistant prostate cancers, progressive PSMA PET positive, have received docetaxel and a prior hormonal androgen receptor pathway inhibitor or novel hormonal therapy, I would say that still, even though there's no overall survival benefit there, there's better PSA response, there's better progression-free survival, there's less toxicity, better quality of life, and the dosing schedule. I haven't even talked about that. Cabazitaxel is given once every 3 weeks. Lutetium PSMA 617, one IV once every 6 weeks. So a little less intense and less cumbersome for you as a patient. These are all in favor of lutetium PSMA 617. So I won't say it's definitive, but I'll say that there's clearly enough hints and benefit to say that if I were in this situation, I might prefer to receive lutetium 617 PSMA. But here's where the prognostic and potentially predictive biomarkers come in. I'm calling PSMA PET here a biomarker because that's what it is. Higher SUV mean uptake from both of these studies showed better outcomes with lutetium PSMA 617. So if you get a PSMA PET and you don't uptake very much, I might think hard about whether lutetium 617 PSMA is right for you. If you don't uptake at all, it's not right for you. You have some sort of prostate cancer, aggressive variant, neuroendocrine, amphicrine. I'm throwing out all these terms, but these are kind of weird prostate cancers, okay, that don't express PSMA. You shouldn't get lutetium 617 PSMA. If you have super high uptake, you should feel reassured that you're more apt to respond and do better with it. If you have kind of lowish uptake, that's a question mark. These studies don't answer that, but those might be situations where, especially if your disease is moving fast, you might lean more towards chemotherapy, cabazitaxel. So I think we can get some hints from these studies as to how to select treatment better for our patients. Okay, the last section. Now this section, I'm not an expert in this, I'm going to say this. It's looking at the fact that lutetium 617 PSMA is a new drug. We in medical oncology haven't used it much. Nuclear medicine is helping us administer it. Radiation oncology is helping us administer it. They haven't used it much. There are new side effects that we're not used to treating. The whole dry mouth thing, xerostomia is what we call it. That's new. We haven't treated that much. So we got to think about it. And we got to come up with good mechanisms and good teaching education modules for our patients and ways to treat it when it happens and ways to prevent it. So what I did in this slide is I spent some time going online. Dr. Google's pretty helpful, but looking up things to avoid and things to do to avoid dry mouth. Okay, so things to avoid. Caffeine dries you out. Alcohol dries you out. Mouthwashes have a lot of alcohol in it, so get a mouthwash that doesn't have alcohol in it. Tobacco dries you out. Smoking or chewing tobacco. Get away from that. Antihistamines and decongestants can dry you out. And just being a mouth breather, that can dry you out too. So these are things not to do. Breathe through your nose. Okay? These are things that you can say, I'm going to cut this out of my life habits, and I'm going to avoid this. So, because I'll tell you, it sounds like not a big deal. Dry mouth sounds like not a big deal. But when your mouth's really dry, no fun. No fun. It's hard to eat. You know, it's kind of gross, right? So you got to find things to do also. And things to do. Sip water regularly. Sips. Add moisture to the air. When you sleep at night, use a room humidifier. You can chew sugar-free gum or suck on sugar-free hard candies to stimulate the flow of saliva. And in particular, there is something called xylitol, which is kind of like an artificial sugar that can be in mouthwash and it can be in certain gums and candies that might be able to help with this. Okay? And that's something to look for. Carboxymethyl cellulose is another ingredient to look for. Hydroxyl ethyl cellulose is another ingredient to look for. So you're going to be looking on your mouthwash labels, on your gum labels, etc. You can find this stuff on Amazon and order some of this. And then the last case, you can try over-the-counter saliva. Sounds gross, right? I don't know many patients that like over-the-counter saliva substitutes. Okay, but it can be tried. Okay, and I would say, you know, these are things to consider, things to avoid, things to do. Now, I have to give credit here to a friend and colleague in the field named Brian Lawenda. He is a radiation oncologist, used to be in Nevada, but now is in Washington, Eastern Washington. And I went recently to ASCO Direct. They have lectures all over the place in the country. They're working, CME providers working in collaboration with ASCO, American Society of Clinical Oncology. And they have all these meetings in different cities, different communities for oncologists in the community to go to. And I gave a talk at one in Las Vegas. I did one in Seattle too, but the one in Las Vegas, Brian was there, and he gave a great talk because he's a radiation doctor. And he gave a great talk looking at alternative methods to help with different side effects of treatment for cancer patients. And again, this is for head and neck cancer patients because head and neck cancer patients get a lot of radiation to the head and neck region, which can cause xerostomia, dry mouth, because it irradiates the salivary glands. Okay, and the reason patients with lutetium get it is because it's essentially radiating the salivary glands. PSMA is actually highly expressed in the salivary glands, and it brings the radiation there and drops it off. So this is a little different because that's directed external beam radiation in head and neck cancer patients. But I'm extrapolating from this because I'm looking for things to try. I can warn patients things to do, things not to do. But when I see it, people are still looking for, well, what can I do now to treat it? Well, Brian actually presented this interesting data, and I borrowed these slides from him, which I think he borrowed from ASCO. But this is in head and neck cancer patients who had radiation-induced dry mouth. And they randomized patients to standard oral hygiene plus true acupuncture, or standard oral hygiene and sham acupuncture. And sham acupuncture is just putting your needles in random places, not in the true pressure points. Okay, now acupuncture is something that I do recommend for certain patients in my clinic. Hot flashes. It can help with, it's good data in breast cancer for that, so I do recommend it for some of my patients with prostate cancer who have really bad hot flashes from their hormonal therapies. Okay? Pain and nausea. There's data to show all this can be beneficial. Don't understand how, but again, we don't understand everything in life, and so we have to accept the data is the data. So I like these studies where they're testing the question of acupuncture with sham acupuncture because we know there is a placebo effect. Well, I'm a human being. We're all human beings. You get something, some treatment, sometimes you think that there's benefit there. Maybe the treatment's not doing anything, but you have this placebo effect. So the way to really test it is not to do acupuncture versus nothing. It's to do acupuncture versus sham acupuncture where you pick random points. And so this is a cool next slide. I'm not going to propose to know anything about these pressure points where they're doing the acupuncture, but this just shows the points where people have been studying acupuncture for thousands of years where this may help with the salivary glands and with xerostomia. And this next slide shows the sham points where they did on the ear that are random points that are not known to help with the salivary glands. And they even use this device where it just kind of pokes in superficially, feels like real acupuncture, but is not real acupuncture. So pretty neat that they did that. And here are the xerostomia symptoms. You can see that over time, week 4, week 8, week 12, that patients that got true acupuncture had the lowest xerostomia scores, and patients that got sham acupuncture also had improvement in xerostomia, over those that, didn't get any acupuncture at all. So what this tells me is that there is a placebo effect. Doing sham acupuncture works, but doing the real thing works even better. And here's Fact G, which is like a 27-question scale for patients with cancer, looking at all kinds of quality of life issues. And this, they have statistics to it. They looked again at no acupuncture, sham acupuncture, and true acupuncture. And you can see that true acupuncture is not only better than no acupuncture, it's better than the placebo effect that you get from sham acupuncture, which again benefits, but the real thing benefits even more. Okay? So this is interesting. I mean, I can't say this is going to work with lutetium-induced xerostomia, but acupuncture, is a reasonably low-cost, low-toxicity thing to try. I have no problems with trying it with some of my patients, and hopefully we'll be able to design some studies that really ask this question as to whether it benefits patients that get xerostomia or dry mouth from lutetium-617. I will just tell you that in addition to this group, there's other efforts ongoing out there. There's a guy, a nuclear medicine guy, he's trained in nuclear medicine and in oncology, and he's on faculty of the National Cancer Institute. His name's Franklin Lynn, and I've looked into some of his work where he's working with a dentist that does cannulation of the salivary glands. And what they do is they cannulate the salivary glands and they inject cold tracer that binds up and soaks up all the PSMA expressing cells in the salivary glands. Then they give you the treatment. So it's already soaked up, so the treatment doesn't go to the wrong place. It doesn't go to the salivary glands and cause the side effects. And so they've been doing it in animal models. I think they're getting ready to do it in humans, so I'm going to keep my eye out for that data as well. And again, this is not my area of expertise, but if there's a new drug with new side effects, I feel like it's my obligation to learn about it and think about any sort of alternative methods that might help my patients to get it. I'm going to wrap up here, and here's my bullet point wrap-ups. The ones that are in bold are the things that I think are prime time now. The other stuff is maybe stuff to come. For patients that are fit with docetaxel who have metastatic hormone-sensitive prostate cancer, consideration should be given to adding either darolutamide or abiraterone to androgen deprivation therapy and docetaxel, triple combination therapy. But we have to recognize this is a highly selected group of patients with de novo metastatic prostate cancer presented with metastatic disease. Triple combination is not the only standard of care. You can have patients with lower volumes of disease, recurrent disease. They're probably not ideal for triple combination therapy, but some sort of treatment intensification with adding abiraterone, enzalutamide, apalutamide, or docetaxel to hormonal therapy might be necessary for these patients, should be strongly considered if you have a patient who's fit enough to receive them. In regards to PARP inhibitors, abiraterone for first-line metastatic castration-resistant prostate cancer, when you add niraparib, if you have one of these select DNA repair gene alterations, that seems to add radiographic progression-free survival benefit. And in an unselected population, adding olaparib to abiraterone, regardless of whether you have a DNA repair gene alteration or not, seems to add radiographic progression-free survival benefit. I still think we need to wait to see overall survival data. It's not mature yet. I still think we need to see what the regulators think about this. I don't know that administering this combination is the definitive right thing to do. Maybe for select patients, but I think we need to wait and see, and more data on sequencing is going to be necessary to know, because again, adding things together may not be better than one after the next. We just can't tell from these studies. Lutetium PSMA 617 very clearly offers survival benefit for those patients who have received a novel hormonal therapy and have received a taxane chemotherapy with metastatic castration-resistant prostate cancer. Similar overall survival benefit to cabazitaxel, but potentially more quality of life benefits and other efficacy benefits like PSA and progression-free survival. So I do kind of lean more towards lutetium PSMA 617 over cabazitaxel for those patients, but I lean even more heavily for those who uptake a lot of PSMA on their PET scan, because it might be a prognostic and potentially predictive biomarker. If you don't uptake so much, I might lean more towards chemotherapy there. And xerostomia, or dry mouth from salivary glands that aren't working well, this is a new side effect of lutetium PSMA 617. We need to monitor for it, prevent, and be thinking about newer treatment methodologies. All right, so with that, I'll wrap up, and I'm sure we're going to have some great discussion with Dr. Moyad now. Thanks so much.